often, let's just stop, discuss some questions that you might have, and then just take it from there. So I hope you enjoy it anyway. So we'll start off by literally just setting the scene. Oh, I do need to show you this slide from the deanery. I have no problems with you taking photos of my slides. In fact, I'll be quite grateful if you want to tag RW Perio, then feel free to do so on Instagram. I have no issues with that. But I think there's a rule about recording things. So just that slide was sent to me, so just be aware of that. Okay, so let's just set the scene. And the presentation is called Periodontal Plastic Surgery. So what does that actually mean? So let's just actually define that. So periodontal plastic surgery is basically surgical procedures performed to prevent or correct anatomic, developmental, traumatic, or disease-induced defects of the gingivae, alveolar bone, or mucosa. It's basically taking a blade to the gingivae or removing some bone. It's any surgical aspect of perio. So I've already kind of showed you some of the examples and already mentioned about crown lengthening and correction of recession defects, but there's more to it. It's also things like, which you may have seen, you know, correction around implants, like if there's a mucosal defect, doing some sort of surgical aspect around that, that's periodontal plastic surgery, gingival augmentation, frenectomies, sometimes prior to implants you can do ridge augmentation, so that's all considered under the periodontal plastic surgery kind of umbrella. So that's what we're talking about today. The ones I've picked, which are the most interesting ones, are the root coverage ones and then the crown lengthening. And I think crown lengthening particularly I want to spend some time on, because if you can understand the techniques, then it's something which you might be able to start applying in practice with a few cases with someone helping you essentially initially. But it's a good skill to have. So let's start off. We're going to spend half the time on gingival recession and half the time on crown lengthening, and then we'll just take questions as we go along. So let's just define gingival recession. I mean, you all know this already. So recession is the apical shift of the gingival margin with exposure of the root surface to the oral cavity. So you can see the image here. Obviously, the bit that's exposed away from the CEJ is your gingival recession. And it's really common. More than 50% of the population have at least one or more sites with gingival recession of 1 millimeter or more. So you will be seeing it in practice. And I think with the why I've included recession is, although you might not be doing the surgery for the recession, you need to know, number one, why it's happened and how you're going to suggest managing it. Because at the moment, I think a lot of people, or especially when I was at dental school, this wasn't taught in a lot of depth at all. You were just taught this is recession, measure it, that's it. But there's a lot more to the story, and it's becoming even more common with things like Invisalign and so on. So this is really important for us to understand. So say your patient comes in, sits on the chair, and they've got recession either in localized areas or across the mouth. And they say to you, oh, well, doc, why do you think my gums have receded? Is it just because I'm brushing a little bit too hard? What's the actual reason for it? Because, you know, my partner brushes his teeth very hard, but he hasn't got recession. So why do I have recession? So the first thing I want to ask you is, can anyone give me examples of what are the factors involved in getting a recession? What are some things? I've already given you over brushing, because that's the most common one. Can anyone think of any more? Great. So Louis says orthodontic treatment, that's spot on. The movement of the teeth in the arch can change. Gingival biotype, very good. So Rory is spot on. So actually the name has now changed, the new classification. It's now called phenotype, not biotype. It means the same thing. It's just phenotype. So Naseba, you said high frenal attachment of frenal pull. So the thing about the frenal pull, it's correct. A lot of people think it's the actual pull that causes a recession, but actually when you look at the studies, it's more the fact that if you've got a high frenum, it's just more difficult to clean around that area. So it's not actually the pull, it's the fact that it's there. It's a local factor. Thickness of the bone, very good. Does anyone know, with regards to bone, any terminology that you can use when there's, without me telling you what it is, when there's something like a hole in the actual alveolar, either a window or a little hole in the bone? Does anyone know what that's called? Very good, fenestration. And the other one is dehiscence. Great, you guys are good. And someone says habitual reasons. What kind of habits, Louise, are you thinking of? Any offers? What particular habits might cause recession? Chewing pens, very good. It's actually a really common one. Nail biting, very good. Good. So we'll come on to all of these. So the first thing to say is all of those are perfect, but let's try and divide these up into categories. Okay. So when you have recession, there's always going to be two categories of factors that you need to take into account when looking at etiology. There's going to be predisposing factors, and a predisposing factor is anything which makes you more likely to get the recession. It doesn't mean you're going to get it, it makes you more likely to get it. So within this can be divided up into bony anatomy, so things like what you've said, especially when the size of the actual root is different to the size of the width of the bone, right? It's inconsistent. So that's a bony anatomy factor. Tooth positioning. So someone said about orthodontic treatment. So you're pushing the tooth into the buccal aspects of the alveolar arch, and that's going to make you more likely. It's a bony anatomy factor. Also anatomically, some like canines at the corner of the arch, they often just emerge very buccally placed. It doesn't have to be just ortho. Any thin buccal bone, what you guys says, it was a dehiscence or a fenestration. You can see that in the image behind. And also, if you lost interproximal bone support, right? So if you've got perio and you've lost interproximal bone, that's going to make you more likely to get recession. So these are all bony anatomy factors, but then you also get soft tissue factors. And this is, again, just a predisposing factor. It's making you more likely to get the recession. So within this, you have a thin, that should say phenotype, actually. So it's thin phenotype, and also a lack of keratinized tissue and no attached keratinized tissue. So before I did my specialist training, I just thought gum was gum, right? But what we need to realize is there's different parts of the gum. So there's keratinized, non-keratinized, but there's also attached and non-attached. And something which is non-keratinized and not attached is bad news, basically. So just bear that in mind. And then also a high frenal attachment, as you said, because of the fact that it's difficult to clean around the area, and also a shallow sulcus. If you've got a very shallow sulcus, I'm sure you've seen patients like this, you like pull the lower lip back and there's just hardly any room there. That also makes it difficult to clean clean at home. It's more difficult and also sometimes uncomfortable. So they're all your soft tissue factors. So they're just predisposing factors. They're making you more likely to get the recession. So now there's precipitating factors, and precipitating factors are ones that will actually end up causing the recession. So this is where things like overzealous brushing comes into play, because not everyone who is an overzealous brusher will actually get recession. Only those who are predisposed to it. So there has to be more to the story. It's not just overbrushing. But the two key precipitating factors are trauma, and within trauma, you've got things which you've already said. So improper toothbrushing, and by improper toothbrushing, it's not just how they're brushing; it's the number of times they're brushing as well. So, you know, if they're brushing like 5 times a day, I often have patients come in, they're like, oh, and they're smiling. They're like, I'm really working hard. I'm brushing 5 times. And they're really happy about it. They think it's a good thing, right? Which you might, because you're cleaning well frequently, but actually overdoing it is not a good thing, right? Having a shower like 10 times a day is probably not going to be great for your skin. Same thing. Improper interdental cleaning as well. So people who overdo the floss, you get these things called Stillman's clefts. And you almost like see a little line on the gingiva. So anything to do with oral hygiene, habits, also as well as pen or pencil chewing, finger biting, fingernail biting is really common. In terms of habits as well, in fact, it's quite interesting. Just before COVID, I had a patient who came in, and really sweet young girl, and she had gingival recession just on her upper incisors. And it was pretty bad, like literally, you know, at least about 6-7 millimeters, but it looked really sore. So I always ask myself when the patient comes in, what are my predisposing factors here? What are my precipitating factors? So the predisposing ones are easy. She had a thin phenotype. She had ortho in the past, and the precipitating factors I just couldn't put my finger on. So I was thinking, oh, is it, you know, does she have any habits? She's not overzealously brushing, because I watched her brush. So what could it be? And she just didn't say anything. I said, are you sure you don't have any habits? And she just said, no, I don't think I have any habits. And then when I did my examination, put all my findings together, and then we were sitting down I was on my desk and she was sitting next to me, and I normally go through all the findings with the patient. And whilst I was explaining to her, obviously she was getting concerned about it, then I saw her actually with her fingernail actually pick on her gums. I was thinking, what's she doing? Like, I've never seen that before. So then I asked her about it, and she goes, oh yeah. And then she literally explained that she does do that. She, I forgot, yeah, I do that. But then she also broke down because she said to me, I've just been through a lot in the last year. I lost my baby, all this like really upsetting stuff. And what she was actually doing was a form of self-harm. So she was actually, it's called gum picking. She was actually literally picking at her gum like people do things like slit their wrists. She was actually picking at her gums. It's very interesting. So there's always a reason, and it might be, you know, something very abstract, but this was her reason. So that's also counted as a habit. Other things like tongue piercings. If you got a tongue piercing, you're going to get lingual recession, right? If you got a lip stud, you're going to get buccal recession. And this might be a previous piercing. So always ask your patient, if it's like a localized defect just on the lower right one, buccally, and you can't find anything else, remember you have to find a reason. Ask them, oh, have you had a lip stud in the past? And they'll be like, yeah, I had one last year, I took it out. So it's a common reason. In fact, I think the people who do these piercings really should consent them for recession, because the number of people who get it is huge. But unfortunately, that's probably not going to happen. Malocclusion. So we didn't say this one actually. So a deep overbite. If you think about the occlusal aspect, you're going to get continual damage to the gingivae palatally, so you can get recession for that reason as well. So that's the first one, trauma. There can only be two options for precipitating factors. It's either trauma related, or the other one is plaque, basically. And this is where the perio patients come in, because they obviously have recession. The inflammation due to the plaque, due to suboptimal oral hygiene, you'll get recession. So hopefully that puts your initial etiology a little bit clearer in your head. So you need to ask yourself, when your patient comes in, okay, Mrs. Smith has recession, why she actually got it. It's not just overzealous brushing, there's more to the story here. So you've got to be a bit like a detective, find why it might happen in terms of predisposing factors, but also what's actually precipitated it. It's not only helpful for you, because you'll need to know those factors, you'll need to control them before doing anything. Even if you don't do surgery, you need to be able to control those factors to prevent this from getting worse. But more importantly, patients want to know, like, why have I got this recession? So if you can say, Mrs. Smith, the reason why you've got this gum recession, firstly, you've got very thin gums. It's just genetics, not your fault, but it's just the way the gums are. You've got very thin gums. Also, after you had your orthodontic treatment, what happened is that they had to push the teeth out in the arch. There's nothing wrong with that. We had to do that to get straight teeth. But sometimes when that happens, the bone can also get very thin. But what actually then ended up causing it is the fact that, you know, you've been over brushing that area and brushing too frequently. That's why you've got the gum recession. So we need to look at each of these factors, the ones that we can change, like the overzealous brushing. Let's try and modify that. So it gives you a better idea of sort of why things happen. So hopefully that, in terms of etiology, is helpful. Also, there are some clues as well when you're looking in the mouth as to why someone's got recession. So if you only have buccal recession, okay, so only buccal recession, and the papilla are intact, so there's no black triangles at all, that's due to overzealous brushing. If it's just buccal recession, overzealous brushing, it's not going to be perio. Stillman's clefts are what we see when people overfloss. Scarring, ulceration on the gingivae, they've been overzealous. So sometimes I get patients, thankfully not too often, where patients will come in and they haven't been following the oral hygiene regime, and they haven't been following what the hygienist has said, and I'm due to see them for their year assessment. And then they come in and literally, like, everywhere the gums are really little ulcers, and I'm like, okay, have you? And then they say, no, I've been working really hard, and you just know it's just that they've been working really hard that night before and not for the last year or 3 months or whatever. So look out for scarring or ulceration. If your soft tissues are inflamed and you've got some black triangles, you've lost interdental support, that is perio. That is due to suboptimal plaque control. So I think your key one to differentiate between is there interproximal attachment loss? If there's not, it's not perio, it's something else. It's probably overzealous brushing. It's quite useful to get patients to bring their oral hygiene aids in with them, so you can actually watch them, because if you show them, are you doing this, they'll just say yes. But you actually need to watch them brush their teeth. You actually need to look at their toothbrush. are the bristles all splayed, and does it look like it, you know? And you ask them, when did you buy this toothbrush or toothbrush head? And if they say to you it's only been a month, well, clearly they're brushing too hard. So they're really useful things to do. Any questions on etiology? Does that help with etiology? Okay, great. So now moving on, once we've found out why they've got it, we actually need to make a diagnosis. We need to classify the recession. Does anyone remember how we classify recession? Does anyone know the classification system? It's a difficult question. You may or may not. Actually, I don't think I was taught this at dental school, but some of you, yeah, very good, Eugene. Perfect. So Miller's classification is what is used to actually classify gingival recession. I won't ask you the details of it. You can see it on the screen. So 1 is essentially where it's not gone past the mucogingival junction and you don't have interproximal attachment loss. 2 is when it goes past the mucogingival junction. And then between 3 and 4, it's just the difference between how much interdental support that you've lost. Now, there are a few problems with Miller's. Firstly, it was created in 1985, which was quite a long time ago, but there are a few issues with it. The differentiating factors between 3 and 4 are not that clear, because all it says is severe interproximal attachment loss, and with 3, it just says, it doesn't say anything really. So what is severe? So it's not very objective. Also, recession just in an interdental papilla can't be classified. Miller's is only to do with buccal recession. You can't even use it for palatal or anything else, literally just buccal. And also recession beyond the mucogingival junction, but keratinized tissue is still present. It doesn't take that into account, and that can actually make a difference when we're treating these cases. If you've still got keratinized tissue, you might do something different to when you don't have keratinized tissue. So there are a few limitations with the system. So we don't really use this anymore, especially since the new classification, because in the new classification, there's a new way of actually defining what gingival recession is. Now, does anyone know this, by the way? I wouldn't expect you to know this detail, but does anyone actually know how we do this in the new classification, how we define recession? Does anyone know how many types there are? Anyone want to guess? Yes, good, Anika, you got it right. So it's 3 types. Very good. So in the new classification, it's actually so much easier than Miller's. It's literally RT 1, 2, and 3, and RT just stands for recession type, basically. Very easy. And these are the details. So gingival recession with no loss of interproximal attachment. Okay, so your interdental papillas are intact, and the interproximal CEJ is clinically not detectable at both the mesial and distal aspects of the tooth. So this is just like a typical case. Interdentally, they're intact. They just got a little bit of buccal recession, initial recession. RT2 is when you have got interproximal attachment loss, but that amount interdentally is less than the buccal one, right? So you've lost maybe 1 or 2 millimeters interdentally, but buccally you've got like a 6 millimeter recession defect. That's RT2. And anything where your interproximal attachment is more than your buccal, right? That's then going into RT3. So I think personally, this you should be using in practice. There's more details to it, which I'm going to show you in a minute, which you don't need to use. But this RT1, 2, and 3 is quite easy to use. Where I would use this, especially, is if like you have a localized, say you have a localized recession defect on the lower incisor. It's really important to actually obviously put it on your pocket chart, but you can actually add that to your diagnosis. Remember last time we went through diagnostic statement, all of that. After that, you could write RT3 affecting lower left 1, something like that. That would be really good to include, because then you can take that into account when you're making your treatment plan. So I think this basic level of classification is important in practice. There's an extension to this where you've got a table and it goes through with various other details on what you might include. So things like recession depth you do anyway, but things like the gingival thickness, because this is quite important. The gingival thickness, when we come to going over treatment, will tell you whether you need a graft or not. And if does anyone know that, I mean, have a guess, what would be the cutoff point in gingival thickness when I would decide I need to supplement this surgery with a graft? Can anyone guess? What would be what's a good amount of thickness for a gingiva? What would I be happy with? What do you call thin? What's anything below what millimeter? Is it not a bad guess? Not bad a guess. It's actually less than that. 1 millimeter. Yeah. So it's 1 millimeter and less is going to need a graft. Keratinized tissue width is important to measure. Also, where is your CEJ? And the reason why they put this in is because some of these cases are to do with abrasion. And when you have abrasion, suddenly your CEJ, you can't see it anymore. So your CEJ, this is what we use to actually classify whether the surgery is successful or not. Because where you want your gingival margin after surgery is at the CEJ, right? But if I can't see the CEJ, how do I measure if I'm successful or not? I don't know. So that needs to be taken into account. Is it detectable? Is it not detectable? And is there any step defect, i.e. is there actually a concavity? And that's important as well, because sometimes, and again, some of these are to do with abrasion, you will get cavities. So they're all the things that if you wanted to, I mean, if you started getting into the gingival recession surgery, I do that. So I need that table, but you can keep it at the back of your mind. But the key thing for you guys is RT 1, 2, and 3 would be really good to implement. Okay, fine. So we've done the assessment, we've done the diagnosis. Our next thing is to decide, do we really need to do anything? Well, firstly, is our patient actually fine? They've got recession, but are they actually getting any problems from it? So what are some of the consequences of recession? What are the, apart from the obvious, which is on the screen, yeah, which is sensitivity, can it cause anything else, recession? Aesthetics, very good. You've got an upper canine with a huge recession defect and a high smile line. That's going to have a huge impact on aesthetics. Anything else? Very good, very, very good. So risk of root caries, right? If you've got a dentine exposed, you're going to get root caries, you're going to get abrasion, all those types of things as well. Very good. So pain sensitivity, poor aesthetics, which you said. Also, when you've got gingival recession, especially when it's localized, it's actually really difficult to clean that localized area. And even if, to be honest, even if it's generalized, it's not the easiest, right? So you're going to get more inflammation, you're going to get plaque retention, root caries, as you said, and abrasion. Perfect. So they're the reasons why, the kind of consequences of recession and the reasons that you need to take into account when deciding what you're actually going to do. Now, regardless of anything, what everyone must do for these patients is manage the modifiable etiological factors, right? Regardless of anything else, whether you do surgery or not, we have to actually try and control the etiological factors. So what I mean by that is if they're over brushing, that needs to be addressed. If they're brushing too many times a day, that needs to be addressed. If it's plaque control, that needs to be addressed. So whatever it is, you have to manage the modifiable etiological factors. But then deciding whether you do surgery or not, there are a few things that you want to take into account. Now, would you do surgery for hypersensitivity? No, not only for that, because actually you can't promise your patient, okay, I'm going to refer you to this periodontist, she's going to do this graft, and the patient says, well, is my sensitivity going to get better? Maybe, we don't know. There's no actual evidence to suggest that it's 100% going to get better. So you can't actually say it's just for hypersensitivity. Would you do it just to prevent root abrasion and caries? Probably not. You might want to actually treat that restoratively, or a combination. Aesthetics, yes, you would, depending on where it is. And aesthetics is really interesting because is it the aesthetics that you think is aesthetic, or is it what the patient thinks is aesthetic? And I have this kind of argument with loads of periodontists all the time. I used to say things like, you know, this is the aesthetic zone because this is where you're smiling, but is it really what you can see, or is it what the patient can see? It's very interesting. I don't think I've made up my mind yet on that, but really you have to take into account what the patient thinks is important for them as well in terms of aesthetics. Keratinized tissue augmentation is definitely one for doing surgery. If you've got really thin gums, really fragile, 100% you want to do surgery there to prevent it from getting worse, for all these reasons. So they're the reasons why, and I would say the biggest one is either aesthetics and preventing progression / augmentating the tissues. So you need to know why, firstly, what problems it's causing and why you might want to treat it surgically. Because before you pick up a blade, you want to have a really good damn reason as to why you're going to cut the gums. It's got to be justified. Now, when we come to doing the actual surgery, the ultimate goal usually is to get root coverage. You want it to look nice. You want the probing depth to be shallow following healing, which interestingly are, when I show you the surgeries, the common question people always ask is, but Rena, don't you, if you're going to move the gum up like that, are you going to get a really deep probing depth? You'd think you would, but you don't. It repairs, it regenerates, and you get shallow probing depth. So that's the aims of the surgery. When we're making decisions, we have to take a few things into account. Patient factors, things like smoking, poor plaque control, no way are you going to do surgery for those patients. You could make it worse. What are the aesthetic requirements? And that will determine how many teeth perhaps that you treat. Do you need to take a graft? Do you need to thicken the tissue as well as covering the recession? Are you dealing with, like, if they've got generalized recession, are you really going to do surgery across every single tooth? Which ones are you actually going to treat? What's the anatomy of the defect like? Do you have a step defect? Do you have abrasion? Is it with gum recession? You know, before I did my training, I just thought gum recession is gum recession. But there's different shapes of gum recession. Is it a narrow defect? Is it a wide defect? What's the depth of the defect? These will all play a role in terms of your decision. So if your patient's sitting in the chair and says to you, okay, doc, I'm going to have this gum recession. I'm going to have this gum recession surgery. I'm interested in getting it sorted. I'm going to go into London to see Rena, but is it really worth it? Like, will I really be able to cover this canine that I'm worried about? Will you guarantee that it's going to get covered? And even if you're not doing the surgery, you need to know what are the factors that are going to affect your root coverage. So things like interdental support. If you don't have interdental support, you've got black triangles everywhere, you're not going to get great coverage because you need that bone. You need the bone as a scaffold. So when you're grafting, if there's no bone there, if there's no interdental support, there's nothing to graft on. So you can't do it for those types of cases. You need a good papilla height. Dimensions of the recession, the smaller the recession in terms of the width and the height or the depth, the better your chances of coverage. So if they come in and they say, look, they've only got a 2-3 millimeter recession, you're probably going to get full coverage on that. What about the convexity? Interestingly, if you've got a concave surface, which is what you normally have with these cases, it actually improves the prognosis and the outcome of the surgery. If you've got like this really bulbous root, like on a canine, and it's really bulbous, it's actually going to be harder to fully cover it. When we do the surgery, what's the flap tension going to be like? You need it tension-free to get the best results. Do they have nice thick gums? If they've got really nice thick gums, more than 1 millimeter, you're going to get a good result. If not, you're going to have to graft. After I've done the surgery, where's the margin going to be? If you can't get it 2 millimeters coronal to the CEJ, right, because it's going to retract when it heals, if you can't get that, you're not going to get full coverage. What's the patient's plaque control like? Are they going to comply? You know, if they're not going to comply, they're not very good with their OH, it's not going to work. So these are some of the things in smoking that you just need to, even if you're not doing the surgery, you need to bear in mind, essentially. So there are various techniques when it comes to actually doing the surgery. Does anyone know, I don't expect you to know the details at all, but has anyone heard of any techniques that we use to treat recession surgically? Don't be afraid to get this wrong. Any answer, any guesses? Perfect. Free gingival graft. Very good, Ruben. So free gingival grafts is a very common one. Anything else for like aesthetic cases? Apically repositioning flap. Okay, almost. Okay, so apically means you're going down. So it's coronally advanced flap, but well done for trying. So you're essentially it's repositioning the flap. So very good. Any others that you've heard of? Some like kind of popular sort of in the media or patients? Very good. That's what I was thinking of, tunneling. So tunneling as well. So great, very good. So you already know some of the techniques. So the way you can divide this up in terms of, without getting too confusing, is the way you're moving the flap, you can define it. So if you're rotating the flap in whichever direction, that's one type of technique. If you're advancing the flap, so rotating is you're coming from the side, advancing is you're coming from above, right, or below. There's various ones that we use there. There's also regenerative procedures, but they're unpredictable, but I've included it just in the list. Tunneling is another one that's used quite commonly. And then you have your random kind of your graft procedures, which is like your free gingival graft, or sometimes you do the procedure above, plus you add in a connective tissue graft. Okay, so I hope that makes sense. So, I mean, you don't need to know this level of detail, but it's nice to know that there's different techniques. The ones I'm going to go over are these: coronally advanced flap for sure, because it's the most common one for aesthetic cases. Tunneling, I don't do that much. I find it's, in my hands, it's less predictable, but it's a technique I'll show you. And then also your graft ones as well, which either are going to supplement what you do, or they're going to be used by themselves as a free gingival graft. So if we look at the free gingival graft first, why does anyone know? Does anyone? Yeah, sorry. Just select all panelists and attendees so we can see the responses. Does anyone know why you might want to do a gingival graft? What advantages does it give you? I'm asking you really tricky questions, but you're getting the answers. So very good. So keratinized tissue, absolutely. Anything else apart from keratinized tissue? What else changes with the gums? It's not just the quality of the gum, but also the very good thickness. Perfect. So free gingival grafts are used in these cases, like here. So here, okay, you've got this lower right one. It's looking really upset. It's looking angry. The problem with this case is actually not that you've got that amount of recession, it's actually the quality of the tissue. The problem here is that the tissue here is super thin, super fragile. So firstly, it's actually hurting the patient when they clean it. They're not purposely missing out that tooth. They've got tons of calculus and plaque there. They're not purposely missing out. It's actually really uncomfortable because of the quality of the tissue. So then they don't clean it. And because the tissue is so fragile and thin, it will recede further. And then, it's got even less resistance and it's going to keep receding. So do not leave these cases. These need addressing. And what we want to try and do here with the free gingival graft, I don't really care if I get coverage or not of this recession defect. I'm not that bothered. What I'm bothered about is improving the quality of the tissue, the thickness of the tissue. So that's all what the free gingival graft does. You do, as a kind of bonus, get some coverage, but that's never your aim. Okay. So all these things you're doing, as well as all those things, when you put a free gingival graft there, you actually increase your sulcus depth. So it allows the patient to clean that area better. So this was post-treatment. And you can see, yes, of course, we've improved the recession, but I don't really care about that. I care about the quality of the tissue. Nice and thick, which means I say to the patient, I call it tough gum. It's nice and thick so that it's going to be comfortable for you to clean. Even if you do get a little bit of plaque there, it's not going to recede further. So it's like protective gum tissue. Okay, it doesn't look very nice. Okay, but I'm not going to be doing this on your upper incisor. It's down here where hopefully no one's going to pull your lip back and stare at it. Okay, so it's more my main concern here is health rather than aesthetics. There are things you can do to try and improve it and make it look nicer, but personally, I want to do something that's predictable. And this is a predictable surgery. If I try and do like a coronally advanced flap here, it's probably not going to work as well. So if I'm going to put a patient through surgery, it needs to be predictable. So this is your free gingival graft. So in terms of how we actually do this, just to give you a background, what we do is we do an initial incision along the mucogingival margin, and that's basically when you pull your lip, anything that's attached, the junction between the attached bit and the non-attached bit that you'll see is your free gingival graft, is your mucogingival junction. And what we do is an incision along there. It's a split thickness incision, meaning you keep the periosteum intact, and it's just getting rid of the outside layers basically. So the reason why we don't want to go down to bone is we need that periosteum as a blood supply. Otherwise the graft's obviously going to have no blood supply. So then what we do is we measure the area. I use the packet, suture packet, the packet is sterile, and I just cut the shape. You can estimate this, but I think it's really mean going to the palate and taking out a chunk that you just might think is the correct size. So I measure it using a suture packet. I use that as a template, put it on the palate, cut out the bit I need, usually about 1.5 millimeter thickness. So it's a fair chunk. When I first started doing these cases, I put a suture on there as well, just in case my nurse suctioned it up. Just helps with control. I don't do that anymore, but it's good if you're starting off. It's a good thing to do. And then you suture. So lots of sutures. Just the key thing here is stability. So we do lots of interrupted sutures. We do a sling suture around, and that provides your compression of the graft. And then it's really clever. The graft then essentially integrates, and it creates its own blood supply. That's why stability is so important. If it's moving around, it's not going to create those vessels. So it needs to stay stable. So stability is the main thing. So how I check that is pull the lower lip back, wiggle it around, make sure it's not moving. Sometimes I give them a stent, just helps with the palatal pain. I just say it's like a really bad burn. It's actually, it can be bad, but it's something you can manage with normal painkillers. And it's kind of a one-off surgery. Once it's done, it's sorted essentially. This is how it heals initially. As long as it looks a bit pink, it means it's got a blood supply. The palate will slowly start to look normal again, and then it will get really white. And the whiteness is what we want, okay? It might not look nice, but it means you've got that nice, thick, keratinized tissue. And there's some other examples. This case I did more recently. On the left was one of my referrers. They did some Invisalign, and unfortunately, it's becoming really common. This was the end outcome, so we now have to deal with this. So we thicken it with a free gingival graft. We've actually managed to get a pretty decent amount of coverage, more than I thought. This is nearly at the apex. So this is a really severe case. This could have not worked. I could actually feel the apex when I was doing the surgery. So I did consent for RCT, didn't need it. And the other one's a bit more of a moderate case, which there was a little frenum there, it's hard to see, but the frenectomy will be part of the surgery, basically. So that's your free gingival graft. The other one, obviously you're not going to do this on the upper teeth where you're not going to put like a white patch on the upper teeth. It's not going to look very nice. So your other technique for aesthetic cases, which is commonly used, is your coronally advanced flap. And it's exactly what it says. You're coronally advancing the flap. And the reason I do this procedure more than any others is just predictability. If I'm going to do surgery on a patient, it needs to work. So with this, what you get is essentially you cover the recession, but sometimes you also thicken it with a graft as well. So here, if there wasn't enough thickness, if remember you now know less than 1 millimeter, I would not only coronally advance it, but I would also stick a little connective tissue underneath it as well. With this procedure, the only requirement is you need to have some keratinized tissue below the apical to the root exposure. If it's all mucosa and completely non-keratinized, why would you then move that to cover the recession? It's not going to work. So that's the only requirement. But usually, to be honest, you do have that amount of keratinized tissue. There's various techniques. They're all kind of different takes on the coronally advanced one. The one we currently use is what we call De Sanctis and Zucchelli. Personally, I think what most periodontists do is they try out a number of techniques, and whatever works in their hands they use. But it's some modification of the coronally advanced flap, and you can see we got full coverage here. So, before I did my specialist training, I actually wouldn't know what to do in this case. I would just say, let's monitor it. Maybe we can put some composite on there. That's like the worst thing to do, right? Because with composite, you're going to find it even difficult to clean the area. They're going to get inflammation. The risk is going to get worse. Are you going to keep adding composite? It's not the right way to treat these things. This is just the examples. How do we do this surgery? Just to give you a bit of background. Well, it's slightly different to the free gingival graft. It's a kind of a trapezoidal sort of shape of the flap, and there's various thicknesses. We do a split thickness first, then we do a full thickness, i.e. we go down to bone, and then we do a split thickness at the top where we're literally just dissecting the muscles to loosen up the flap, to allow it to pull it down, basically. The reason why the middle bit is full thickness is that middle bit is going to cover your recession. And so we want the thickest amount of tissue we can get. So we try and make that full thickness. We do it split thickness, the most coronal part, because that's where you're going to attach your flap. So if you go to bone, like we said with the free gingival graft, you need something there. So you do these incisions, you check the mobility. You can see from that picture there's quite some tension apically. So I'd want to dissect that even more, and then pull it down. It's 2 millimeters coronal to the CEJ, suture it everywhere. Essentially, again, stability is key here. Here, I didn't need a connective tissue because you can see the thickness is really super thick. It's like 2 millimeters thick. I didn't need to add a graft, but what I would do if this was thin, before I coronally advance it, I add in a little connective tissue and then stitch it up. It's just slight variation. Initially, it will look a little bit lumpy and bumpy, and then it will start to look a lot better over time, and it will retract as it heals. That's why you have to place it 2 millimeters in advance to CEJ. This is another example, not so severe. Again, this was post Invisalign. So this is, I get a lot of cases referred because of Invisalign. It's really important when you start doing things, if you are doing Invisalign and things like that, make sure it's in your consent form, recession. This was a case, interesting one I did with one of the dentists, and here we did use composite bonding, but only to the CEJ. So what we did is he did the composites up to the CEJ, and then let me see if I can use this pen. So he did the composites. Oh, it's not going to work. Okay, anyway, so he did the composites, you all know where the CJ is, to the CJ, and then I did a coronally advanced flap and a connective tissue graft underneath, so it worked beautifully. You know, if you didn't know this stuff existed, what most people would do in this case is just slap on composite everywhere, and this is just going to make it worse. It's not actually treating the condition properly. So that's your coronally advanced flap. I would say those two are the biggest things that I do in practice. There are other techniques like the tunneling. I find it's quite technique sensitive, but what a tunnel is literally what it says. You're not actually making any vertical incisions. You're literally loosening up the flap through the buccal aspect of the tooth and creating a tunnel through the teeth, and literally then just pulling that down and stitching it up. It's really tricky. You need special equipment for it. It's meant to be more minimally invasive, but I'm not so sure of the benefits because you do get quite a lot of swelling after, but it's coming along in terms of how popular it is. So it's a one to be aware of. So this is where I do my incisions, literally just on those buccal aspects. And then you can see I've created a tunnel. That tunneling knife goes in between, and I can a bit loosen up the tissues. It's very interesting how it works. And then you suture it. So for this patient, we did quite a few surgeries. I ended up needing to do another coronally advanced flap after. So that kind of put me off the tunnel, but it's a technique that we use. You can see we did a free gingival graft here on the lower as well. So that was her before. There. So I mean, again, if I saw this when I was at your stage, no one had actually told me this stuff existed. Just knowing that this is a thing we can do is a good thing. This is a surgery. I don't know if you'll be able to hear the sound, but I'll just play this. This is a more complex surgery for those of you like, I know some of you emailed me after and said you were quite interested in Perio, so I've included this for you just to make you even more excited. This isn't me, but this is a really good program. So I'll just play this. If it gets boring, I'll go on to the next slide. Then we'll move on to crown lengthening. So this is more of a generalized case, and they're doing coronally advanced flap. So you can see this is where he's raising the flap and checking the mobility. And it's a combination of split, full split thickness. Sometimes you need vertical relieving incisions, sometimes you don't. You try and minimize it anteriorly because you get scars. So here you can see on the upper right one, he hasn't actually done a vertical relieving incision, which is fine. As long as you get the mobility, that's the key thing. Then you actually have to debride the root surfaces, because if there's any debris on that at all, the surgery won't work very well. So it looks a bit aggressive here, but you're meant to gently debride the root surfaces after that. And then what you see him doing is he'll actually de-epithelialize the papillae, because that's the bit that you need to stick onto. So he'll actually remove a layer of the papilla, because if you have epithelium there, your flap is not going to integrate. So you'll see that next. going to speed it up a bit. So he's now slicing off just the epithelium. Okay, and then it just involves suturing up. So you've got the mobility and then lots of sutures here. So you've got like a sling suture, which actually pulls the gum down with it, sling it over the tooth. Normally do quite a number of those, and then single interrupted. So this is quite impressive. This is why I did Perio, stuff like this. It's really good fun. So I just wanted to show you kind of the more advanced cases. So before we move on to crown lengthening, just another 2 minutes. If we do take grafts, we normally take it from the palate. It helps thicken the tissue. It helps prevent the recession from progressing. If you've got like a deep cavity, like an abrasion defect, rather than putting composite, you can actually, in that hole, you can put some connective tissue as well. It's probably a better way of treating it. So there's lots of reasons why you might take this connective tissue graft. But the other graft we take is a free gingival graft. This is what we saw. We've seen this already when you take it from the palate. That's the whole, literally all the layers. Whereas if we do a connective tissue, which is like this one, you don't need the top layer. You're just taking the connective tissue. Remember, you have epithelium on top, then connective tissue. So for this type of surgery, you just peel off the epithelium and you grab the connective tissue from underneath. So post-operatively, as you can see, there's various ways of doing it. It's much nicer rather than your free gingival graft. That's the one that hurts. When taking grafts, I mean, really the key thing here is risk of bleeding. So it's really, really important that you know where all the arteries are. You guys, a lot of you have done what you're doing, mat spasm and things like that. Those kind of skills really do come into play here. Sometimes we put a bit of Surgicel before suturing as well. That can help. But the key thing is bleeding. There are alternatives when it comes to graft. You'll hear of things like Alloderm, those kind of things, but they're never as predictable as your gold standard connective tissue graft. I don't use them. The idea of it, like one of them is like from humans, dead humans, obviously. I'd rather not. I'd rather just use, I know it's a bit more invasive that you've got to use their connective tissue graft, but it's their own tissue, it's going to work. The other ones are porcine derived, things like that, which is fine, but they're just not as predictable. In terms of interdental papillae reconstruction, we do not have a predictable surgery yet. I actually had a patient, I'm not doing online consultations for obvious reasons because for gums it's pretty difficult, but I had a patient that was actually referred, they must have called their dentist, and they actually, during COVID, it can go two ways. I think people are like analysing their smiles as well. And anyway, she had some actress, she has an interdental black triangles that have opened up post-ortho. And she was literally like, can you give me a call? Can you do anything about this? And I had to say no. It's really upsetting actually, because I'm not going to say I can fix something when I can't. So there's literally nothing we can do about this. The key thing is we need to make sure it's not getting worse. So she said, well, I've heard that you can put fillers in, like people are injecting, like Botox fillers and all those types of things into the interdental papillae. And I said, well, you won't find a specialist doing that. It's not evidence-based. Don't ever follow people just because they're doing it doesn't mean it's going to work. In fact, I think if you're going to inject like a filler, what's going to happen with the blood supply there? What's going to happen long term? There's nothing we can do right now about black triangles. You can do things like gingival veneers and stuff like that, but surgically there's nothing you can do. So just bear that in mind. There's no bone there, remember. With these cases, your standard post-op procedures, if you are interested in this kind of stuff, I think it's great. Even if you don't have to be a specialist to do this, you just need to do some courses. But you need magnification, you need illumination. You're going to have to invest in some microsurgical techniques. It's all very delicate. Some of you doing oral surgery, the difference is this has to be very, very delicate. Every millimeter or half a millimeter matters. If you want to do this, I think I sent you the information. I'm doing a hands-on thing. You have to do this hands-on. There's no way you can do this. But just by looking through a lecture, I want to show you on pigs' heads and things like that. So if you're interested, especially next year, on stuff like this, including crown lengthening, hands-on, what I normally do is show you on pigs' heads, and then I'll do some cases with you, and then you just build up. You can pick and choose the ones you do in practice. But I think it's a great skill to have. especially crown lengthening. So hopefully that was helpful. Any questions on recession? Are you guys enjoying this so far? Not too boring, hopefully? Any questions at all? Is anyone still there? Hopefully you haven't all like nodded off. Okay. All right, brilliant. Good. Let's go. Moving on to crown lengthening. So crown lengthening definition: surgical removal of hard and soft parental tissues to gain supragingival tooth length, allowing for longer clinical crowns and re-establishment of the biologic width. Crown lengthening is like the opposite to recession. Recession we're trying to cover, crown lengthening we're trying to expose, so it's the opposite. Interestingly, in the new classification, the biologic width, the terminology has now changed to supracrestal tissue attachment. I don't really care if you use biologic width. I quite like biologic width. You're not going to get in trouble for using it, but if you want it to be perfect, supracrestal tissue attachment is your kind of right word to use. But what it means, it's your junctional epithelium and your connective tissue. So usually that's about 2 millimeters according to the studies. But if you include the sulcus depth, which is helpful to do because you don't know how deep the sulcus is, or usually, and you want to you make it complicated, just remember 3 millimeters from the gingival margin to the alveolar crest should always be 3 millimeters. That's your biologic width or your supracrestal tissue attachment. Jaspreet, I'm just going to answer your question before we move on. So with buccal recession and lower incisor, when there is a dehiscence, is the risk of relapse high? No, it's not. As long as you've done a free gingival graft and it's there, they won't get relapse. Free gingival graft is basically for life. I've not known of any cases where it will come back again. So good question. Okay, so that's your biologic width. So, and what you're doing with crown lengthening is you're re-establishing that biologic width. So there's various indications for crown lengthening. There can be restorative indications. So things like inadequate amount of tooth tissue, like you want to save a tooth, but you don't have that 2 millimeter ferrule, so you can put do your endo and put your crown in. So you might want to crown lengthen to get that tooth structure. If you've got subgingival fractures, caries, perforations, as long as it's in the coronal third, you might want to crown lengthen to be able to access it. Also, unfortunately, like this picture in the background, when dentists don't understand what biologic width is, they just slap on all these veneers and crowns, they will invade the biologic width, and then you now have to do crown lengthening to correct it. So you'll see these cases, it looks like someone's got a fell tip and just drawn along the gingival margin. Their crowns might look nice for a couple of months, and then they'll look like this. And then you're gonna have to do crown lengthening and replace all those crowns again to re-establish your biologic width. So, you know, this is why, even if you don't do crown lengthening, I hope some of you will, but even if you don't, you need to understand the kind of biology behind biologic width, so you don't invade it and respect it, essentially. Other indications for crown lengthening are aesthetics, so like gummy smiles, short clinical crown heights, uneven gingival contours. This patient here, very gummy smile. She's actually got a condition called altered passive eruption, which is an interesting one if you want to look it up. It's when your gingival margin doesn't retract to the right level. So you get eruption of teeth, but you also get passive eruption of the gums. As the teeth erupt, you get the gums retract as well. And if they don't if they don't retract, sorry, I can't speak today, then you get something called altered passive eruption. So that's when your CEJ, her CEJ is well under the gum, right? So it's not that she just got a gummy smile, she actually the gum hasn't retracted to the right level. So her gum margin is actually on enamel. It's quite interesting, it's not uncommon, it's like 12% incidence. So look it up, altered passive eruption, interesting condition. Other indications, I guess, if you've got things like gingival overgrowth and hereditary gingival fibromatosis, by removing that bulk of tissue, technically, you can call it crown lengthening. So that's kind of other category. So that's why you might do crown lengthening. Now, limiting factors. Can anyone tell me what are the limiting factors? What might make me think, I'm not so sure if I should do crown lengthening in this case? What might you think I better take this into account? What kind of things? We've said a few of them because they're same with any type of surgery, but what do you guys think? Oh, wow. Okay, that's really good. I wasn't expecting someone to say that straight away, so that's really good. So Nisaba said crown root ratio. Very good, right? If you're going to crown lengthen and then you've only got, the patient's already had bone loss due to perio, and you're going to have a tiny little root left, probably not a good idea. Probably want to extract that tooth. Active perio, very good. You want to treat the disease first, very good. If you've got like a pocket of 9 millimeters, and the same thing, not just perio, but a suboptimal root canal treatment, and you know, the tooth's just not restoratively, are you doing heroics here by doing crown lengthening, or are you actually doing something useful? So that does need to be taken into account as well. Very good. Any others? There's more obvious ones actually. These are really good. What things did we say for aesthetic zone? Very good. You guys getting the more difficult ones. What did we say for recession? Why wouldn't I do recession surgery? So both Soba and Hina, what you've said is very correct. If you're compromising the adjacent tooth, like if you're doing crown lengthening on a 4 and they've got high smile line, it's going to impact on the 3, you don't want to be doing it. It might actually compromise. Remember, when you're crown lengthening one tooth, you're not really crown lengthening one tooth, you're crown lengthening 3 teeth, because you've got to go either side for your flap, you've got to go either side for your bone as well. And very good. What I was getting to is smoking, poor OH, all those types of things. Phenotype normally is not a problem. But that is a good point. So these are some of the things you've already said. You've covered all these. The only thing you didn't cover is, which tricky one, is high furcation entrance. If you're a really high furcation entrance and then you're going to crown lengthen, you're going to expose that furcation. Is that a good idea or not? It might be okay. You might just need to take it into account, but it does need to be taken into account. Really, the key with crown lengthening, the actual procedure itself is easy. It's the understanding of the case and the planning. This is why I'm spending a bit of time on this. So how do we go about doing it? So this is a complicated one, so I want to go through this with you. He also had Altopasso eruption, Gummy Smile, didn't like the way his teeth looked. I mean, those bridges aren't helping, right? They're awful, they're not very nice at all. So it doesn't help in terms of making the teeth look the right size. But this is what you do is obviously an extra examination, especially for aesthetic cases. It's not so relevant for restorative crown lengthening. For aesthetic cases, what's a smile like? That's going to help you decide how many teeth you're going to treat. You then do your intraoral examination, exclude disease. We don't want any disease. If you need to do an endo, do the endo first, because there's no point me doing a crown lengthening surgery and then the endo fails. What was the point of the surgery, right? Look at the keratinized tissue. I'm going to come onto this, but it will affect the surgical approach you take. Look at other things that you'd normally do. You definitely need radiographs, and you might want to take into account the occlusion as well. Now, the key thing is your planning, and the key thing is knowing what your reference point or your finish line is going to be. So this particular case that we're talking about, this is more of an aesthetic case. We removed the bridges, by the way. And then here, what I did, this is more complicated, but I just want to go through it with you, is we did a wax up of where I want the teeth to look, or where I want the margin to be. So I did a wax up, and then I created a stent of that wax up, which gave me a surgical guide of where I want to do my incisions. So my reference point here is the stent. So there are various reference points that you might have. It might be the CEJ, right? Like if it's that case where, like the one we saw initially, is your CEJ your reference point? Is there a reference point on the tooth? Like if you've got a restorative margin and you know you need that exposed, is that your reference point? Is it an existing restoration? Is it a provisional restoration? You need to know what your reference point is, because you're going to need 3 millimeters from your reference point to the bone margin, 3 millimeters, remember, to take into account the sulcus depth. You also need to look at, when you're planning, the keratinized tissue. How much keratinized tissue do you have? Normally, on most occasions, you'll have plenty. But if you've got a patient where, you know, there's hardly any keratinized tissue, these are all showing keratinized tissue. It's the junction. Remember, if you pull the lip, you'll see where it's up to, the attached tissue. If you don't have this, right, and literally you're just pulling the lip and there's literally going straight to the mucosa, you're going to need a different approach, because you don't want to be hacking away that type of tissue. You want to preserve keratinized tissue. You also need to look at the bone. Where's the bone? So you'll be doing this radiographically, right? Sometimes you can do something called bone sounding, where you actually numb up and you probe right down to feel where the bone is. I don't normally do that, just use a radiographic assessment. But here you need to know where the bone is, because you need to have approximately 3 millimeters between the bone margin and your reference point. So here, right, this patient here on the right, her CEJ is well below that gingival margin. She's also got passive eruption. But if I then removed that gum and I probed and I found, or I looked radiographically and the bone level's way, like far away, more than 3 millimeters, I don't then need to remove bone for this crown lengthening case. I just need to do a gingivectomy. So all you have to make sure is if you have space between your gingival margin, or that's my reference point here, and the bone or the CEJ. If it's not 3 millimeters, you need to make 3 millimeters by removing bone. If it's already 3 millimeters, you don't then need to remove bone. See what I mean? Because I've got my biologic width. That's bone sounding. So this is her radiographs. Can you see on the upper incisors, like 3 to 3, she's already lost a ton of bone. So actually, all I did here was a gingivectomy because I removed the gum and then the bone already had space. The spaces have been made naturally. So therefore, I didn't have to remove bone. So radiographic assessment is really, really important. And this just says the same thing. PAs are very, very useful in these cases. Also, when you're planning, you need to take into account gingival aesthetics. So if you're doing like a 3 to 3 case, you need to know, what am I aiming for? Obviously, you look at the individual and how their gums are, but you've got to use some guidance as well. So apical coronally or lateral incisor will be a 1 millimeter coronal to the central and the canine. And then in terms of your actual gingival zenith, so your gingival zenith is your highest point on the gingival margin. On the central incisor, it will be about 1 millimeter distal. You can see on that line there. On the lateral, it'll be about 0.4 millimeter distal to the midline. And then your canine is normally bang on in the middle. So if you keep those at the back of your mind, it's useful to know what your ideal is, essentially. And that was done by a study by Chu, 2009, if you want to have a look at that. But that's generally what we use. Also, as a kind of advanced tip, you do also need to take into account other things like racial pigmentation. Because if you have racial pigmentation, interestingly, if you cut a certain way, you're going to either remove that pigmentation and you get a scar, or you want to keep it. And you really want to keep it. So your angle of your blade, this is, I mean, more advanced stuff, but matters as well. If you've got tapered roots, you might end up getting black triangles. You need to take that into account. Also, if you are going to get black triangles, think about restoratively. There's a study which shows if you've got 5 millimeters between the alveolar crest and the contact point, you won't get a black triangle. So can you try and recreate, can you try and get that less than 5 millimeters by maybe doing a composite, etc. So there's other things. I mean, people think crown lengthening is sometimes easy peasy, but there's quite a lot to do it and actually do it properly. There's quite a lot to take into account. So that's when you're planning, and there are various approaches. The one in yellow, for 95% of cases, you'll be fine. It's when you've got adequate keratinized tissue, and generally your bone needs removing. You need that 3 millimeter space, so you do a bit of osseous resection as well. The only time you wouldn't do this is if you had inadequate keratinized tissue, then you're not going to cut away that keratinized tissue. You're then just going to apically position that flap. Make sense? So usually it's cut away the gum, lift up the flap, see where the bone is. If it's not 3 millimeters, you remove the bone till it's 3 millimeters, and then you stitch up. That's your kind of usual technique. And it will work for most of your cases. So flap design, for going back to our case, we would do some incisions. Now here, I've actually left the interdental papilla intact anteriorly between the centrals because I didn't want to risk it. And this is an aesthetic case, and I don't need to get access to the papilla, so you can actually do modifications to this technique as well. But we essentially cut the gum to the level we need to. So here, my reference point was the CEJ. Underneath there, I need it to be at the CEJ where it should have always been. Then we cut the gum away, we reflect the flap, and usually when you're doing flap design, for example, if you're doing one tooth, you always go one tooth either side of it to get you that access. If you're doing like the upper right 6, you're going to have to go to the 5 and the 7. You need to preserve the keratinized tissue, so if you're going to be hacking away, the point is you need lots more left. Keratinized tissue is important for oral hygiene and to preserve just the periodontal health, so you don't want to be taking it away. You need to go beyond the mucogingival junction to be able to actually move that flap around as well. So once you've raised the flap, you look at where the bone is, and then you need to basically remove 3 millimeters from the CEJ to the to where we need 3 millimeters from the CUJ to the alveolar crest. If you don't have it, you keep removing the bone. And there's various things we use to remove the bone, including things like hand chisels, which are not recommended, but things like burrs, usually either with a surgical surgical fast handpiece or slow handpiece that has water. So when you're actually removing it, you have to make sure that it's nice and moist. Otherwise, I mean, you guys know the consequences more than me, because a lot of you are doing surgery right now. And also, you need to make sure it's nice and smooth, i.e., you're not just removing bone from that upper right. I'd say that's probably a 5. You're removing bone from either side. It needs to have a gradual rise and fall of the contour. That's why when you're consenting these patients, you have to consent for bone removal of either side. Sensitivity, you guys said these things already. Sensitivity, you're going to get either side. So if you've got a compromised tooth, it may not be a good idea. So once you've removed the bone, you stitch up, very just straightforward, single interrupters usually. There's variations you can do, but single interrupted works quite well. And then post-op, like the recession surgery, no brushing for 2 weeks, analgesia, ice pack. It's not normally that painful at all, actually. And then you continue with your restorative work. So here I did a little bit of this. I did this case quite a long time ago when I used to do restorative stuff as well. Stopped doing restorative, I just do perio now, but I did some bonding. I did resin retained bridge on one side, and then I did the implant retained crown on the other side. The reason why I didn't do implants on both sides was the root of the central on the right side was very angulated, so we didn't have space to get an implant in there. But you can see he looks a lot better than he did before. It looks all a bit more in proportion. So they're the kind of basic steps, and it heals very, very nicely. So this is another example. So this is the sequence to put it all together now. A is obviously the assessment. B, remove the gum first. C, raise the flap. D, see where the bone is. If it's not 3 millimeters from your reference point, remove some. E, stitch it up. F, make it heal. That's it. It's actually, once you get it in your head, the steps, it's honestly, it's not too bad at all. These are some other examples. This was for a case, you've seen this one. Now here, she had a gummy smile. Now, she said to me, I've been to so many dentists, and all they said is that I need orthognathic surgery to correct this. Now, to be honest, she probably does, because it's at the position of her jaw as well, to correct it fully. But look what we can do. This was a case that I remember the bone was already quite high up. I just did a gingivectomy here. It took like an hour, but it's literally changed her life. When she came in, she wouldn't even move her hand from her mouth. That's how negative her confidence level was. And when she came and when it healed up, she was literally a completely different person. You know, and then you might want to do some Invisalign, you might want to do some whitening, you might want to do some bonding to perfect it. Quite honestly, for her, that was enough, and that's fair enough. So she was happy at that point. This was the one that you saw earlier, if you remember, where we did some crown lengthening. So I did the crown lengthening initially. You can see it starting to look a lot more in proportion. I'm at her CEJ now. Before the CEJ was covered, that was my reference point. And then the dentist who I was working with did some beautiful composite veneers. She's an actress, and basically every time they were, I think they analysed, obviously they analysed them to give them improvement points, but they were all the people analysing her saying, oh, you've got a very gummy smile. I thought it was really mean, actually, but anyway, they were saying your smile needs improving. So she wasn't even that bothered about it, but she was doing it for her career. And she looks, I mean, she looks great both ways, but she looks completely different. So it's made a big difference to her smile. Even just one tooth. I mean, it's cases like this, you might be able to do yourself, like just one tooth. But because it's aesthetic, you still need to do it really well, because it's right at the front of the mouth. But just look how much difference it makes. Huge, huge difference. This is a restorative example, right? Upper 6. It's just one area, measly, where the margin's going subgingivally. If you want to do this properly, it needs crown lengthening. You want to do the endo, crown lengthen, and then you can see the crown's put on nicely now. All the margins are supragingivally. It's not going subgingival. So if you can do these kind of simple cases, it's great. It's a more complex case. This is actually more palatal wear. So we had to do, before the dentist did the crowns, we had to do some crown lengthening palatally. So there's kind of a difference between restorative crown lengthening and aesthetic crown lengthening. The basic understanding and the basic steps are the same, but there's a few little differences when you're doing it just aesthetically and just doing it restoratively. So restoratively, you're normally working at the back, usually, you know, releasing incisions, vertical incisions are not the end of the world. Whereas if I was doing a case like that upper one, if I start then putting 2 vertical incisions, is not good. I'm going to get probably some scarring there. So try and avoid them. Your reference point for restorative crown lengthening is either your restorative margin or a provisional restoration, all those types of things. Whereas for your aesthetic cases, it's usually your CEJ where you want to aim for. Stents are great for aesthetic, but you don't, I mean, it's a bit of a hassle to use it for restorative. If you're only doing aesthetic cases, like that 3 to 3 one, you don't then need to raise a palatal flap because you don't need to. It's not aesthetic. You just do buccal. Whereas for restorative, you're going around the whole tooth usually. And the same thing applies for your actual osseous reduction as well. Wound dressings posteriorly, like you can get things like periodontal dressings like, what's it called? Oh my God, it slipped out of my head. But you can get periodontal dressings that you can put on, that's it, Copac, thank you, that you can use for restorative. You can tell I'm not been doing dentistry for a while, or feeling it now. But anyway, Copac, you can use that for restorative crown lengthening because it's going to really press down tissues, but you're not going to put, like, it looks like chewing gum, you're not going to put that on 3 to 3. It's not going to look very nice. Also for aesthetic, which is important in your consent process, I would always consent for a revision surgery, because the recession may, the gum may actually continue to change. And if you do get a bit of overgrowth, you might need to do a little bit more surgery to make it perfect. So I would always consent for a revision surgery. It's never going to be as drastic as the first one, but it is something to take into account. So just be aware the principles are the same, but find out, are you doing a restorative case? Or are you doing an aesthetic case? Because there'll be some slight differences with that. The key thing, again, even if you're not doing crown lengthening, you need to know, when can I restore this tooth? So for a tooth in the posterior region, that's not in the aesthetic zone, like that case we saw with upper 6, you can put on your definitive crown at 3 months. You want your provisional on there as soon as possible because the provisionals help with the healing. So say you did the endo, then I did the crown lengthening, and I took the stitches out at 2 weeks, you can slap your provisional on straight away. You might even have it on already, right? But that can go, there's no time limit for that. But you can't put your actual definitive restoration on, your definitive, whatever it is, whether it's restoration or crown or whatever, until 3 months, because things can change. And actually for aesthetic cases, your textbook answer for this is 6 months. If you're doing a highly detailed case for upper 3 to 3, and if that gingival margin at 5 months goes slightly apical or coronal, and you've already put your veneers on, you all know the consequence, that tiny little 1 millimeter recession, that patient's going to complain. They need to do the whole thing again. So it's just not worth rushing these cases. I have to say a few of my referrers do place it beforehand, but I mean, you got to make sure you're confident with it. So I personally would say 6 months. You can put provisionals on. Provisionals look great, but wait for 6 months till everything heals up, and then put on your final cases. You can get, the margin's going to continue to change, right? And normally, in terms of typical things that happen for people with thick phenotypes, you generally do get a little bit of coronal relapse. So you just have to be really careful for those cases. And I guess the key difference between what we saw with the recession cases and these cases post-operatively is after 2 weeks, with the recession one, you can go nowhere near it with your toothbrush because it's so delicate. Whereas for these cases, you start brushing. You really start brushing after 2 weeks to prevent the gum from coming back to where it wants to be. So the home care is slightly different for both cases. You can be a bit more aggressive with the crown lengthening. So I think even if you're not doing the crown lengthening, it's important for you to know what are the timings from a restorative aspect. When can I do my provisional? When can I do my definitive? So that's important to remember, and it's important to be patient, I think, because it's only it's not going to be most patients you'll get away with it if you do it a bit earlier, but it'll be that odd patient that will come back and it really messes. I'm saying from experience, it really messes things up. So just stick with the textbook. So I hope that's helpful in terms of crown lengthening, understanding the indications, understanding factors you need to take into account in terms of contraindicating factors, and then factors that you're going to be using in your planning, and then actually the steps that are required. The key thing really is understanding the biologic width, or the supracrestal tissue attachment, as we now call it. That's the bit which everyone gets confused about, and then they start using like lasers just to remove bits of gum. That's fine. It's only if you've got that 3 millimeters. If you don't have that 3 millimeters and you're just removing a bit of gum, you have invaded the biologic width, and there will be consequences like inflammation, like pocketing, like bone loss, and then it just gets messy. So it's worth doing things properly, essentially. Any questions on crown lengthening? Does it all make sense? Have I explained it clearly enough? You guys still there? Okay. Good. So just to summarize, I think it's great that we've done this session, because I mean, when I was at your stage, I literally had no, I mean, you guys are really good, honestly. I'm not just saying that, like, you know a lot. Perhaps it's for the experience you're getting this year as well. But most people, and including me at that stage, no clue